David, unfortunately, has his wife very ill and phoned us at 1 o'clock today to say that he couldn't make it. So I thought to myself, what are we going to do? We could do a number of things, but I thought the best option was to invite the CEO of PCFA, Dr. Anthony Lowe himself, to come and talk to us tonight. Now, it still has the same theme that Dave was going to talk about, because as the peak body for prostate cancer, we're very interested in making sure that we get evidence-based data so that we can go and do our stuff. So Anthony, with his background, is a past master in all this. So without any further ado, I'll introduce Dr. Anthony Lowe. Thanks, Anthony.
Thanks, David. Is that working? Yes. Okay, thank you very much. Well, good evening, everyone. It's a great pleasure to be here again. Last time I was here, the wonderful Professor Suzanne Chambers was speaking, so it's a great pleasure to be back. What David asked me to speak about this evening is the work that PCFA is doing at the moment in advocacy and awareness raising, and in particular how we've changed our approach to be much more evidence-based in work that we do. I heard a number of you, as we were waiting to start, talking about the campaign around abiraterone, Zytiga, and that's actually a good example. When we had the campaign to get docetaxel listed on PBS, it was very much driven by an emotive appeal that we have to get a chemotherapy listed on the PBS for men. It's really important. And that passion, the passion of the prostate cancer community is really important. But if we want to get things done these days, if we want to talk to government and we want to achieve what we need to achieve, then we also need to be very evidence-based in what we do. We need to present not only the emotive argument for what we want, but also the rational argument as well. That's very, very important. David asked me to say a little bit about the Community Attitude Survey. I hope that everybody has seen this publication that we launched at the State Library of New South Wales in September last year. It is a very good and interesting example of being evidence-based. It's the 10th year of us doing a Community Attitude Survey. It actually started as some work that the Victorian Board did 10 years ago for what became the Be a Man campaign. And we've been busily doing a Community Attitude Survey asking men about their attitudes towards prostate cancer as an important health issue, attitudes towards testing for prostate cancer, and attitudes towards support services for 10 years. But it was only last year that we took the step to actually write it up into a publication, and it's been very successful for us. So now when David and I go and see politicians, we've been to see Gillian Skinner here in New South Wales. Last week we were down in Canberra and David and I met up with Peter Dutton. We always talk about this Community Attitude Survey because it's the voice of our community. It's more than 1,200 men. It's a very credible sample size, but it really talks about the issues that are important to the prostate cancer community. So we see, for example, very clearly that men do see prostate cancer as an important, one of the top 5 health issues for the community generally, and the most important health issue facing men. We see that men are being tested very frequently for prostate cancer. Sometimes I think we despair a little bit about the fact that men don't go and talk to their doctor, don't get themselves tested. But what we actually see is that something like 30 to 40% of men between 45 and 74 are being tested annually. And what we see very interestingly as well is it's general practitioners that are actually at the forefront of influencing men to get tested. And we also see from the Community Attitude Survey that despite what some in health professionals think, which is that men are not good at seeking out supportive care services, in the survey at least 25% of men that we talked to who had been diagnosed with prostate cancer did seek out a support group, either a PCFA support group or a cancer council support group, and they found it a very valuable source of information and advice. So it's good to see what we actually know coming through in the Community Attitude Survey. And if we want to influence, which we do, politicians for the changes that we want to see, then it's very important that we that we have it written up in this kind of form. It's a credible survey methodology, it's a credible sample size, and those sorts of things. And I also just wanted to show you one other document that we've recently produced. You would be aware, of course, that we've been working on the Prostate Cancer Specialist Nursing Programme for almost 2 years now, and Julie Sykes, our Director of Nursing, has been leading that effort. We've written up the practice framework and the competency standards in the first of a series of monographs in prostate cancer. Every time I say we've started a series of monographs, people go, what's a monograph? So a monograph is a small book on a single subject, usually by a single author. So we're going to have a number of these. We've got a couple that we're working on at the moment. We've been doing a lot of work in the gay community on prostate cancer, and we've got one that we're writing up at the moment on what prostate cancer means for gay men and their relationships and their community. So we're writing up a series of these monographs, and we're going to use them as our evidence base again for talking with politicians and so on and so forth. And we thought it was really important to write this up because what I'm pleased to be able to tell you is that through our association with Movember, the Irish and the Canadians and around the world are starting to take up the idea of prostate cancer specialist nurses, an idea that PCFA pioneered, and they're starting to, with Movember support, put in programs themselves in their own countries, which is absolutely fantastic. But we wanted to make sure that everyone understands that we came up with the idea first. It's an Australian initiative, and it's really important to understand that. So that's the practice framework. It's a little bit dry for those of you who are not professional nurses, but the other ones that are coming will be interesting and important. So that's what we're doing in making sure that all our work is evidence-based. And as part of that, we've started working quite closely with Griffith University, with Suzanne Chambers. Suzanne, of course, is a long-standing supporter of PCFA and a great friend of ours, and Cancer Council Queensland, that she's been associated with for a long time, is also a great friend of PCFA. And we've come up with the idea that by partnering with an academic group like Suzanne's group, we can really make progress in some of these issues. And I wanted to talk about a project that I'm working on at the moment in partnership, not actually with Suzanne, but some health economists at Griffith University. And I actually wanted to ask for your support in completing a little online survey that we've got going that should take about 20 minutes to complete. So those of you who by now have had the chance to have a look at this month's prostate news will have seen on page 14 an article, an opinion piece that David and I wrote called "How Much Is This All Going to Cost?" And what it's about is the financial implications of treatment of being diagnosed with prostate cancer. Because one of the interesting things is actually we don't know that much about the cost of being treated for prostate cancer. Individually, I'm sure everybody knows about their own costs. Interestingly, I asked David, I said, David, you would know how much it costs to go through that treatment. And he said to me, well, no, not really. I just paid the bills. I never added them all up. I don't know what it all added up to. And that probably is a situation that a number of people are in.
That's because he's rich.
Yeah.
You should ask Pam.
Yeah, well, that's probably right. That's probably right, Margie.
I thought it was a fair answer.
But it is interesting. So what we say in the article is, how much is it all going to cost? It isn't the first thing that's on your mind when you get diagnosed with prostate cancer, for sure. There are a million other things to think about. But at some point, you come, I know, in talking to people, that you come to the point of thinking, well, I hope my health insurance covers this, or I hope I get reimbursed through the public system, or I wonder what it is all going to cost. So what we know, of course, is that the cost of being treated for prostate cancer depends on the treatment modality, whether you undergo active surveillance or radical prostatectomy or external beam radiation or brachytherapy. They all have different costs associated with them. I know Pam spends a fair amount of time calling up different medical professionals on behalf of people that have contacted the Sandoz to find out what different things would be. And it does depend, we all know, whether you're in the public system, whether you're in the private system, whether you've got health insurance, what health insurance you've got, and also who the particular doctor that you happen to be dealing with is. But it's not just the costs of primary treatment. Think about some other things. So what about secondary and subsequent treatment? So what about salvage radiotherapy if you had to have that? What about androgen deprivation therapy? What about chemotherapy? What are all those things going to cost if you have to face that? What about the direct costs of additional treatment to manage side effects? So penile prosthesis, for example, or incontinence sling. What are those costs? Are they going to be reimbursed? What about the indirect costs of treatment? We're here experiencing the car parking situation at the Sydney Adventist Hospital. What we actually know is that travel and accommodation and car parking costs are actually significant additional costs that many patients face. Then you've got additional life costs like incontinence pads, exercise programs if you're on androgen deprivation therapy. We know through PCFA's own research program, where we've been funding Professor Daniel Galvao and Professor Rob Newton at Edith Cowan, doing work on exercise regimes for men on androgen deprivation therapy, that it's very important, but it doesn't necessarily come free. And what about loss of income? Not everybody is retired when they face a diagnosis of prostate cancer. What about the amount of time you've got to take off work? What about the loss of income? If you've got a working spouse, what about the time that your spouse has to take off to support you and help you and take you to appointments and all of those kind of things? And finally, what about increased financial services costs? So you get diagnosed with cancer, what about increased insurance premiums and those sorts of things? So what we do know is it can all add up to a significant amount. And we also, of course, know that prostate cancer, the risk rises very steeply with age. And so what we know is that those costs are often being faced by people who are retired and are on limited income. So what we want to do as an organisation is to come to grips with what are those costs for different treatment modalities, and to get some science, if you like, around the issue. Because, as I say, as it turns out, if you talk to health professionals, you talk to people in the public system, you talk to people like yourselves, people seem to be all over the map in terms of what it might actually cost and how you might go about meeting those costs. And what we want to be able to do is two things. We want to be able to develop resources for the prostate cancer community to help men and their families face a diagnosis of prostate cancer, think about those issues, what they might do. For example, Departments of Veterans Affairs for incontinence pads, early release of superannuation, those sorts of things. What we do know is that men and their families don't always get the best advice about what they can do, and they don't always act on that because they don't necessarily know what options are available to them. So we want to develop some resources, but we also, probably more importantly than that, we want to use the evidence base that we gather for advocacy for change. So we want to be able to go to the Department of Health, for example, and others, and talk about some of the things, the costs, and the costs that are not reimbursed through the public system, but jolly well ought to be reimbursed through the public system. And we want to be able to go to talk to the health insurers about the fact that, for example, if you take robotic surgery, some insurers will reimburse for that, others will not, and it does depend on where you are in the country. Bill Richmond, chapter chair in Victoria, talks about that quite eloquently. In his situation with his insurer, he paid a $20,000 bill to have robotic surgery. What he discovered afterwards is if he'd been with a different health insurer, it would have been fully reimbursed. But he never knew that. He never knew that if he'd been with a different insurer, he would have had a very different outcome. So we want to inform people about that, but we also want to use it to advocate for health insurers to say, you need to get your act together. You all need to be doing the same thing. Why are you doing something different than this other insurer? Why are you doing something different in New South Wales and Victoria and so on and so forth? So it's very, very important. And what we also know, sadly, is that men without private health insurance face significantly longer wait times than men with private health insurance, and also the treatment options that are available to them are different than the treatment options that are available in a practical sense. Obviously, in a theoretical sense, all the treatment options are available, but in a real practical sense, the treatment options for men in the public system are more limited than the treatment options available to men who have got private health insurance. So we want to use the information to advocate for change. We want to advocate with the public through the public system, and we want to advocate with private health insurers. And we're working with Dr. Louisa Gordon at Griffith Centre for Applied Health Economics. She's a health economist, and she's done some very good work in breast cancer. And what she showed in her work that she did in breast cancer is that some of these indirect costs, like travel and accommodation, can be very significant actually, but often go unrecognised. You just sort of, you put up with them, you deal with them on a day-to-day basis, and you never actually add it up and see what it all meant and see whether we can advocate for change with that as well. Now, there's another part of the survey that we're very interested in as well. So it's not just about costs, but it's about the financial impact, full stop. Because what I hear a lot, and I think it's something that's not talked about a great deal, but I'm starting to hear it more and more, is the issues for men who are still in the workforce at the time they get diagnosed. So they start with issues like, how long am I going to have to be off work? Am I going to have significant unpaid time off work? How's all that going to work? I've heard a significant number of men talk about worries about managing back in the workforce when they get back in the workforce. We were at a workshop the other day, and a man was talking about the fact that he worried because of some of his continence problems that he might have an odour problem, and that might count against him in the workforce. So there are those kind of things. But I think, sadly, there's also anecdotal evidence, and I'm very interested through this study to get more of a handle on this, about workforce discrimination as a result of being diagnosed with prostate cancer or any cancer. So what are we talking about? We're talking about sort of silent employment discrimination, not getting that promotion opportunity perhaps, or maybe not getting the pay rise that you expected to get, or possibly even finding yourself on a redundancy list that you might not have found yourself on if you hadn't been diagnosed with cancer. And I know it's not something that's talked about a lot, but I hear by talking to people, and I see in some of the nods in the audience this evening, that it's an important issue, and I think it's an issue we've got to get to grips with. We've got to get some genuine data, and we've got to advocate for change, because it's not acceptable in this day and age for people to face that kind of discrimination simply because they've been diagnosed with prostate cancer. So that's the work. We're working, as I said, with Louisa Gordon, and what we want to do is we want to develop information and resources, but we want to use it to advocate for change. Pardon me. And I've got some letters here, which I might hand out and leave with you, which are just an invitation to be part of the project and a link to the online survey. It'll take about 20 minutes to complete. In my PowerPoint presentation, I've got a nice screenshot of the survey, but we can't see that this evening.
I'll apologise to you.
That's all right, David. And it's rather a complicated, one of those things with all kinds of question marks and whatnots in the thing. But I'm hoping that we might be able to persuade Pam to email out as part of the newsletter the whole group, because we're hoping over the next month to recruit a significant number of men and their families who've been through that journey, just to gather more information on what it all costs.
Thanks again for standing in at the last minute, because it's a very important part of PCFA's work, and we're very fortunate to have a fellow like Anthony leading the charge here because of his scientific background. It's all about evidence. I mean, 16 and a half years ago, we could have gone and beat our chests and been all emotional about things, but these days when Anthony and I and others get down to the corridors of power, there's no use going on like that. You've got to have evidence, and this is what it's all about. So I'm sure there are questions of Anthony.
I'd say before I ask my question, I must say I have written about abiraterone, and as well as stating the clinical situation as well as I could, I also came in on the emotional one and said, as a grandfather of 8 children, they're all those children are interested in my surviving, and et cetera, et cetera. I think a point like that is probably well worth making.
Yes. Agreed.
Right. Then my question is, I was diagnosed July year before last, Gleason score 80, Gleason score 8, and it was thought because I was then 86, I'm now 88, I might say, naturally, that I, we won't go into the risk. Yeah, anyway, I was put on Zoladex.
Yep.
Now, my question is one about the limitation of the period on which one stays on Zoladex. Good gracious. Urologist, right, medical oncologist.
Yep.
He says that it's that I could I can consider myself on remission at the present time, and that I could, when I have, after I've had my what would be about eighth implant, next June, in the coming June, that I could then have a rest from the Zoladex. But I just wonder what the present thinking is about this.
You answer.
Well, first of all, what I need to say is a bit of a sort of a health warning, if you like. I'm not a medical doctor, so that's important to say. The first thing, just to respond to your point about abiraterone and the lobbying for it, I think that passion and the emotive side of it is an extremely important part of the advocacy and the lobbying. What we have to be able to do, in my opinion at least, is to put the passion together with so we've got both the emotional and the rational argument, and I think those two together is what we need. So I'm not suggesting at all, and I know you weren't suggesting that I was, that we leave the passion behind and we only use the rational argument. Now, the thing about hormone therapy is it's variable. How long being on hormone therapy will actually be effective, but eventually being on hormone therapy, you come to a situation, or most people come to a situation where it's no longer effective. And at the moment, the treatment would be chemotherapy, docetaxel. What we're hoping with abiraterone is that at the moment, abiraterone is available only as a treatment where you've been on hormone therapy, the hormone therapy's failed, then you go on to a chemotherapy, the chemotherapy's failed, and then you go on to abiraterone. But what everybody hopes is that abiraterone will eventually, and some of the other therapies that are coming along, like MDV 3100 and so on, will fundamentally transform the treatment of advanced prostate cancer. So first of all, that it will be used in a pre-chemotherapy setting, and there is a phase 3 clinical trial that's just wrapped up in the US that shows its effectiveness, and possibly also much earlier in the piece, you know, as soon as you've got advanced prostate cancer. So the big hope of these new therapies that are coming along is that they will fundamentally, over the next 10 years, they'll fundamentally transform the treatment of advanced prostate cancer because they're a lot less toxic than the cytotoxic chemotherapies like the docetaxel and so on, the taxanes. Abiraterone itself is taken orally, which is very important. You don't have to go into hospital to have infusion and so on. So they're very important treatments. So I hope that helps answer your question.
Okay, Bruce.
Yeah, thank you for your most informative, impromptu information for us. I've got a more general question. Can you tell the group something about the sort of interface between PCFA and the Cancer Council?
Yes, happy to do that. So our model, it's not as effective all the way around the country, but we're working hard on it, is to work as closely with cancer councils in various states and territories as we possibly can. I would say that probably the best example of that is Cancer Council Queensland. We have a fantastic relationship with Cancer Council Queensland. Jeff Dunn, Professor Jeff Dunn, who's the CEO there, has been a great supporter of ours over a number of years, and Suzanne Chambers herself used to work for Cancer Council Queensland, as you probably know. They've been tremendous supporters, both morally and also in helping us with facilities, their auditorium and so on and so forth. And in fact, they've just done a fantastic thing for us, which is to sublease some space in their new building that they've got just across the way from their main office, where we've got our own walk-in door. We've got our own sort of separate office, if you like, but it's co-located with Cancer Council Queensland. So that's the model. We're working hard to replicate that, if you like, everywhere. We have great relationship with most of the cancer councils. And we're also working very closely with Professor Ian Ulver, who's Chief Executive of Cancer Council Australia, on our PSA testing guidelines. So we're working with his team on developing the guidelines. We're going to put the guidelines on the wiki platform. So what we're looking for, what we're working towards, is a really close working relationship. And what we very much encourage with support groups is to have a good, strong relationship both with Prostate Cancer Foundation of Australia, PCFA, but also with the Cancer Council as well. They've got some fantastic training programs and resources and so on, and it's important to for support groups to avail themselves of their information, resources, and so on and so forth.
And if my information is correct, Margie over there is the latest qualified person to come through a training program.
Oh, yes,
As of yesterday.
Very good.
So well done, Margie.
Yeah.
I was just wondering when you're going to try and come up with some sort of cost base, and it depends on which specialist you go to. There's a huge range of charges you can get.
Yes.
And just for my own experience, but it's not a prostate experience, but I had, due to an office fire back in 1994, I developed, due to the toxic nature of the smoke, I developed chronic sinusitis. Mm. I went initially to a specialist and I had sinus surgery, and the charges seemed to be pretty reasonable, and it was mostly covered. There wasn't a huge gap. Then later on, about 3 years later, it recurred, and I didn't particularly want to go back because I didn't think, even though I thought the surgery was well done, I didn't think the aftercare was very well done at all. Mm. And the second guy, his charges were very much more, and I had to pay in advance the full amount before I could even get booked into the hospital. Mm. He wouldn't even book me in.
Yep.
But there was a huge difference, the gap. So I'm just sort of trying to relate two like things. Obviously, you don't go and get two radical prostatectomies, but
yep.
So I can't relate it that way. So I was just wondering how there must be some way you could sort of come up with an average, I guess, between what should be a reasonable cost, and maybe get some of these more expensive guys to hold it back a bit. I don't know.
Yeah, no, that.
But in your example, Tony, they're both up your nose, aren't they?
Yeah. Well, the second one, what he's done works, so I've got to go with it. So
yeah. So no, that's absolutely right.
Can I just add something to that?
Yeah, of course. Sorry.
Because not only is it
different between different specialists, but also the same specialist will have different charges depending on what he thinks you are worth, which I think is absolutely disgusting. It's got nothing to do. Every other, most other professions these days are highly regulated as to what they charge, and you're allowed to see the charges up front. Here we have a case where, you've got expensive shoes on, you must be able to pay $10,000 for this operation. Somebody else comes dressed in rags and they'll give it to them for nothing. It's ludicrous.
So on the variability of cost, that's absolutely right. And that's why we need to be working with experienced health economists like the group at the Centre of Applied Health Economics at Griffith University, because we're doing two things as part of this. We're using the Cancer Council Queensland ProsCan data, which is a very big data set capturing costs of treatment, different modalities, and we're also doing this, if you like, adjunct survey that goes with it. But it's all in the statistical analysis that's done. So we'll see when we've got the results. We're very confident that we'll be able to pull some good averages and so on out. And of course, it does vary. We all know that. But what we're trying to do is understand what that variability is, and also what, if you like, what the average is or what the baseline is, so that we can give people some guidance as to what the costs might be. Because there's very little data out there at the moment.
Yeah. And consistent with what Anthony's saying, I mean, we armed with this information, not only will we be able to go with much more confidence to government and to health insurance companies, which will help change the paradigm, but the other thing is that we can put pressure with evidence back to the medical colleges, like the Society of Urologists, for instance, the radiation oncologists, the medical oncologists. We start giving facts back to them of what we've got and what we've been able to put our hands on, and come up with some pretty reasonable arguments to them.
That's exactly right. But to be able to have those discussions, we need to be able to go, well, we've done this work, you know, the sample size is statistically credible, it's statistically significant, and what we're seeing is this variability. Why is that? What would that be about?
So that covers off your point, Nigel. Now, another question over here.
Hi, I would just like to ask, now Ian has written a letter to Tanya Plibersek and various other members, including Tony Abbott's office, which he's had no reply from anyone except Tony Abbott's office phoned.
Right.
But what I mean, he wrote from an emotive point of view primarily. But now I'd like to also, now we're going to start another campaign and target all the shadow cabinet ministers, plus the whoever they might like to be when Ms Gillard does her reshuffle. We would like to target those as well. But now we need to get on to, as you said, we need to produce evidence-based information to apply for this drug to be put on a PBS. How can you assist us with, I mean, we're only lay people, how can you assist us with evidence-based material to use?
Well, if you would like to give me a call tomorrow, we can talk about that. I mean, we've got a lot of evidence around it. Just to explain the situation, so the Pharmaceutical Benefits Advisory Committee at their November meeting made a recommendation to the Minister to list abiraterone. So she's sitting with a recommendation for a listing. But the Pharmaceutical Benefits Advisory Committee is just that. It's an advisory committee. The Minister doesn't have to follow that if she doesn't want to. And what's been happening with the whole debate around budget surpluses and all of that is that they've been holding off for as long as they possibly can. She's basically got, under the guidance, 6 months in which to make a decision. So they've been holding off for the longest period of time. So I think right now, actually, what we do need is those emotive letters, because they've got the evidence. The Pharmaceutical Benefits Advisory Committee has recommended, if you like, they've made that rational argument that it should be listed. That's understood by the Minister and the Minister's office. What we need now is for them to understand that there are votes in it, if you like, for holding off or not holding off. So happy to talk, of course, about the evidence base, but right here and now I think what we need is as many letters as possible going to particularly the Minister for Health, but also the others that you talked about, the Peter Duttons, the Tony Abbotts, the Wayne Swans, all of these people, because what we need is that consumer groundswell of pressure. They will listen to that.
So what number should I ring to get some?
Oh, we'll give it to you.
Yeah.
Yeah.
Yes.
Okay. Final question. Jeff?
Anthony, another issue with costs is the medical safety net.
Yep.
They don't count your medical expenses at hospital.
Yep.
And only outside of the hospital scheme.
Yes.
That's an issue that a lot of us are faced with when we are suffering from prostate cancer and other diseases like that, where we've got reoccurring costs all the time.
Yes.
And that's an issue that should be addressed by Medicare and the Health Commission.
Indeed. So we've got some questions in the online survey about the safety net, both the pharmaceutical safety net and the benefits safety net. So we're interested to understand exactly the point that you're making. We know that it is an issue, but we're interested to gather the evidence around that. And we've got some good work. A lot of work and thought has gone into designing the question set in the survey, so I do encourage you. I've done it myself and Pam's done it. It doesn't take long to do, but it's got some good questions about issues like that, and also some straightforward things like, did you get reimbursed all the things that you expected that you would, or are there other things that you know, what was your experience? Were there things above and beyond what was covered by your private health insurance if you've got private health insurance, or was it covered? So we've got some good questions to capture that data, and we will use that, as David says, to advocate for change. Obviously, we've got to think about, once we've got it all in, we'll have to think about the priority and what issues we tackle first. We're interested to tackle this issue of the variability of what private health insurers do, because we think we can get some good traction. We actually think that, by and large, the issue is the private health insurers don't actually know that they've got such variability, and that it should be fairly easy to make an argument with them that they need to sort of sort themselves out.
We're certainly going to remain confident until we have to be otherwise, but we are confident, aren't we?
Yeah, we are.
Yeah. Okay. Pamela. I said one last question.
Sorry, I was just going to add that we do have a guy that is involved with this group, hasn't been for a long time, but he does work for one of the private medical funds, so he might be someone that you need to talk to.
That'll be good. Thank you.
Okay. Well, thank you very much, and it's my opportunity now on your behalf to thank Anthony, who came with 5 minutes, well, a bit longer than 5 minutes notice, but it's a very important subject, and we're grateful for his presence, and we encourage you, the full details of the survey will be in the next newsletter, which will be out soon. Says David.
Says David. And if you're interested, these letters here, just they're standard letters that we have to have because of the ethics and so on, but it's got the link to the survey.
Thanks again, Anthony.
Thank you, Dave.